the Health Board. So first of all, welcome to the guests who are attending in person and those who are joining us online on the live stream. Today's meeting will also be available on the Health Board's YouTube channel following conclusion of the meeting. So welcome in the room as well to Joanne Lane, Divisional Nurse, and Dr. Catherine Davis, Consultant in the Primary Care and Community Division, who will be supporting the patient, supporting the presentation of the patient story today. Moving on to apologies for the meeting. We've had apologies from Will Smart, Vice Chair, and from Ulan Jones, Independent Member. On to declarations of interest, 1.3, if there's anything that anybody here on the table needs to declare on the agenda. No. That's then on item 2, which is the consent agenda. Anything on the consent agenda members wish to bring forward or consent, we're also on there. Okay, on to item 3 then, which is the experience story. This is a patient story, compassionate care in community. And I'll hand over to our guests, if that's okay, to present this to the board. Okay.
Thank you very much, and thank you for giving us this opportunity to come and share our patient story today. So I think from the introductions, I'm Joanne Lane, I'm the Division of Primary Care and Community.
I'm Dr. Catherine Davis, I'm the Clinical Director of Frailty and work in Lady Borough.
Can I ask you to come forward to the table so we can hear you better? Okay.
Onto the main table.
Thank you, Watson.
Okay, thank you. So just to say, Kath and I have been working for some time to develop some case studies, this being one, to raise awareness of the valuable role really that community services play in supporting individuals in being cared for closer to home, in line with the drivers that we've got within the division around place-based care. During this time, the older person's pathway has begun to evolve. And we recognise that this story, Val's story, perfectly illustrates some of the key principles of the model. Through a coordinated, person-centred approach, you'll see that her journey demonstrates the benefit of integrated working across the community health care and social care services, enabling care to be delivered to the right place at the right time and as close to home as possible. We are hoping that her story highlights the positive impact that collaborative community-based care can have on both patient outcomes and experience. So you can see on the first slide, this is just a little bit of background and pen picture of Val. I think anybody who's worked in community will realise that this is not a unique story, that we serve many patients with similar complex needs, ageing population, and multiple long-term conditions. So and this is probably not the most complex that we care for in the community, but we felt that it depicted many of our populations that we serve out there. So Val's 82 years old and is currently living alone, although she benefits from a strong support from her family network. Prior to 2020, she was completely independent, mobile, and living a full active life despite managing several of her long-term health conditions. Like many people in COVID, prolonged periods of home led to deconditioning, and her health needs became more complex during this time, and she began to receive support from frailty services from 2022 onwards. You can see from the slide her medical history. She's got multiple complex conditions. She's got type 2 diabetes, rheumatoid arthritis, angina, which became much more unstable, heart failure, and you will see she did then develop Parkinson's disease, which became a complication of postural hypertension, which was increasing her need for frailty services. These conditions created additional challenges and increased her vulnerability to deterioration. So when working with Val, it was important to understand not only her clinical needs, but what mattered to her. So you'll see from the video that she shares with us that maintaining her independence for as long as possible was a priority. Remain connected with her family and friends and to be actively involved in decisions around her care. She loves life and wanted to make the most of every opportunity she's got. As a result of her health conditions, she was facing numerous risks living alone at home, which included falls, which you'll see, hospital admission, further deterioration and deconditioning, social isolation, and difficulty managing her activities of daily living, and the increased risks associated with her advancing frailty. So what has made the difference for her is the coordinated support provided around her. Family and friends have played a vital role alongside community services. As you'll see from the enablers, assisted technology played an important part. She would use her Alexa for managing her medication. She had a pendant alarm. So she used quite a lot of assisted technology as well to keep her safe within the house. And through proactive planning with regular multidisciplinary team involvement, services were planned to work together with Val to support her goals and maintain her quality of life. We believe her story demonstrates how a person-centred, place-based approach can support older people to remain safe and independent at home, focusing on what matters and also the balance in risks and responsibilities. So you will see she lived with risks, but that was balanced against her own rights and responsibility and choice to do that. Most importantly, it shows how care closer to home can improve both patient experience and outcomes while ensuring that what matters to the individual remains at the centre of everything we do. We go on to the next slide, please.
This very complicated slide shows the interventions that we've had via frailty, which is quite a lot, and some outpatient clinics, just ensuring some continuity of care through her journey. Frailty services played an increasingly significant role in supporting Val over the last 3 years, providing proactive coordinated care that enables her to remain safely at home whilst managing her increasingly complex care needs. Whilst there have been numerous interventions during this period, there's a couple just to highlight and make examples that demonstrate the impact of frailty model and the principles of the older care pathway. Between January 2022 and November 2023, Val had multiple episodes of high temperatures, weakness, vomiting and decline in function. Each episode we treated as an infection. However, every time the antibiotics stopped, her condition deteriorated. Throughout this period, Val remained under frailty team oversight as a virtual patient, had regular monitoring, assessment and coordination of investigations via consultant-led care. Following extensive diagnostic work that include ultrasound and CT, she was diagnosed with a retroperitoneal abscess, which is an abscess quite deep within your abdomen, which was eventually identified as the underlying cause. This resulted in Val's only hospital admission during this time, where there was a coordinated overnight stay at YYF, where she was then transferred to GUH at 8 AM in the morning. She went to theatre for drainage of the abscess by midday and was transferred to the urology ward at the Royal Gwent later that evening. She had 10 days of inpatient treatment of intravenous antibiotics and drained the abscess, some rehabilitation and recovery, and Val was discharged home with ongoing frailty, where we supported her to overcome the abscess, monitored her bloods, linked very closely with urology to ensure that the abscess was fully drained and she was recovering. Falls management has been another important aspect of Val's care. She experienced 2 significant long live falls on the floor for a number of hours, where she was usually in the night, where she was reluctant to disturb her family members, which is common, and preferred to wait till the daylight hours to contact anybody. On both occasions, she had rapid assessment and intervention from the frailty team, and this enabled Val to be safely managed at home and avoid hospital admission each time. Following one of the falls, Val then developed jaundice and was just generally unwell. Prompt assessment through the team identified acute cholangitis, which we managed at home with antibiotics, close monitoring and regular review, preventing the need for hospital admission. More recently, the emphasis of care has shifted towards supporting Val with the progression of her long-term conditions. She had worsening heart failure, advancing Parkinson's disease with episodes of angina at home, alongside significant symptoms of severe postural hypotension, making her more unsteady on her feet. Through multidisciplinary work in medication optimisation, symptom management, proactive monitoring and anticipatory care planning, community services have continued to support Val's wish to remain at home while maintaining her quality of life and independence. As you can see from the slide, through Val's journey, we've anticipated and avoided an estimated 14 hospital admissions. Aside from clinically necessary admissions for treatment, Val required 1 attendance to SDEC to exclude a pulmonary embolism following some right-sided chest pain, where she was seen the same day and returned home the same day following exclusion. Val's story is a powerful example of delivering the right care in the right place at the right time, and it demonstrates how proactive frailty management, multidisciplinary collaboration and community-based interventions can support people with complex needs to remain at home, maintain their independence and receive care aligned to what matters most to them. Her journey embodies the principle of care closer to home and the older person's pathway, ensuring hospital-based care is utilised only when clinically necessary and providing support across the services when required. Just move on to the next slide.
And so, as you can see, over the last few years, as Kath has said, the frailty team has become an integral part of Val's life and care journey. Beyond managing individual episodes of illness, the team have provided something far more important to Val, which is trust, continuity and reassurance that this is been a possibility for her to stay at home with this support. She has developed a trusted relationship with the team, knowing that the support is available when she needs it. This has given her and her family confidence with a sense of safety and security, allowing concerns to be addressed quickly and appropriately. The team has helped Val maintain a sense of control rather than care being done to her. Decisions have been made with her, understanding what matters most to Val. Maintaining her independence, staying connected with families and friends, and being involved in decisions about her care has shaped every intervention.
So shared planning and decision making with our team, Val and her family, to anticipate problems, manage risk and respond proactively to changes in her condition. This includes regular assessment by senior members of the team, monitoring, treatment and coordination of service, enabling many episodes of deterioration to be managed safely at home, preventing avoidable hospital admissions. Most importantly, the support is provided has helped preserve Val's quality of life. Despite increasing frailty and complex health needs, Val has remained in her own home, surrounded by people and things that matter most. When reflecting on her journey, Val believes that the support provided by the frailty team has not only enabled her to live life as she wants, but to live and has actually added years to her life. For us, that's perhaps the most powerful measure of success and a true reflection of care closer to home and the older person pathway. And we'll just move on to hear from Val herself.
One, two, three, four, five. My name is Val. I'm 82 and I met this team a few years ago when I was ill, and they've kept me out of hospital. I've had kidney trouble, I've had liver trouble, and they've been back and forth to keep me in my own home. I've had the bed down and I've had the toilet put in downstairs to keep me downstairs. And when I was really ill with a abscess on my kidney for 12 months, Dr. Davis persevered and kept me out all the time. I was in pain and suffering. Well, my confidence with the team, I feel safe when they come, and I feel safe I can get in touch with them if I need them.
What was your favourite, Val?
Well, you are, Steve. You are. You're the only one that can get any bloods.
My name's Dr. Davis. I'm the Clinical Director for the Frailty team and Clinical Lead in Caerphilly. We lead a hospital at home service that's available throughout the whole of the Gwent area, which is a consultant-led team, and we deliver IV treatment in patients' houses, bloods, any other medical treatment that might be required with the aim for hospital avoidance, along with early pull out of hospital for those that is suitable for. That's delivered by an MDT, including our healthcare support workers, nurses, physios, OTs, and our emergency carers if needed, as well as social workers. First met Val back in 2022 when she had her abscess that we helped manage at home, and with a brief hospital admission under urology where they did drain the abscess, and she came back home. She's been in and out of our service multiple times over the years with different things. We've managed a bit of her heart failure, titrating up her medication, and multiple other infections that Val's had. So most recently, she had a fall and developed jaundice, and the family were aware that her colour wasn't right and referred her through to us. We came out and assessed Val in the house, took her bloods, started her on some antibiotics. Her bloods weren't too bad, so we managed with oral antibiotics, and then she stayed at home. We've monitored her and she's improved without ever needing a hospital admission. I've got a prescription now for a new tablet. This should help with that dizziness that you're getting, okay? The family will pick that up for you.
Yeah, thank you.
And I've spoken to them as well. And then we'll come back out in a week or two and just repeat that blood pressure and see how you're doing.
Oh, thank you ever so much.
We'll let the Parkinson's team know all the changes as well.
Thank you ever so much.
All right.
I'm very grateful for all you do for me. I started being ill, sweating and shivers, and I had scans, I had x-rays, nothing was ever found. And then Dr. Davis decided then to go back, start from the beginning of my procedure of having scans, and it was only like nearly after 12 months that it was found.
I looked after him, she? Not yet. Sorry. Starting.
We can just see if it'll come back, but it might be worth stopping and restarting it at that point to see if it'll restart.
Was taken into the Grange and then down to the Gwent, and then when I come home, Dr. Davis's team come in and looked after all I had to have done. And that was the time then that I was really poorly.
We've done some more work recently in conjunction with the Parkinson's team, because Val's recently been diagnosed with Parkinson's disease. She has got some postural elements, so she's quite dizzy when she stands up and is at high risk of falls. So we're starting to introduce some medication with the Parkinson's teams and us working together collaboratively to try and reduce that risk of falling to keep Val safe in the house, as per her wishes.
My name's Joanne Lane. I'm
Oh, good. Did you plot that? So you didn't want to see yourself on the screen? Sorry.
I'm the Divisional Nurse for Primary Care and Community Division, and the purpose of sharing Val's story is to showcase what we can provide within the community, which includes the principles of place-based care and the care closer to home model. So Val's story encompasses the principles of both place-based care and care closer to home. It highlights the principles of the what matters conversation and how this is balanced with risk and autonomy.
Not doing fully, is it? You see it, not quite, yeah. IT doesn't always work. Bring it back a bit and leave them maybe.
And how this is balanced with risk and autonomy. Val's highlighted the risk she lives with on a day-to-day basis. She's at risk of falls, she's at risk of ongoing deterioration, she's at risk of social isolation, she's at risk of polypharmacy and medication errors, and also she's at risk of not being able to care for herself at times. What does keep her safe at home is the principles of that care closer to home model, primarily her family and the support network that she receives from the community network. It's the environment and the equipment that's been provided to enable her to stay independent. These improvements within assisted technology, which she uses her Alexa to remind her with her tablets, and then as needed we move out to the healthcare professionals, which she then seeks help from her primary and community care team as necessary. I think it's been clear what matters to Val. She's made it clear she wants to stay at home with the people that she loves around her. Quality is important to her, and being in the environment that she wants to stay in. What she doesn't want is to be admitted to hospital and to have unnecessary medical interventions that are not going to bring her any benefit.
It meant a lot for me to stay at home. I just did. And I got a good family behind me. I definitely didn't want to go into hospital. Me and Dr. Davis worked on a plan for me to stay at home as long as possible. If it come to that I had to go in, I don't want to be resuscitated. I've made arrangements and done all the signing of that, and made anything that can possibly be done, I've done, to keep myself in my own four walls. What matters to me is staying at home, and Dr. Davis and their team have made plans that I can stay at home as long as it's possible. I hope sharing my story will mean that other people can have the care at home like I've had. So I can't thank them enough for what they do for me.
I'm aware of what matters to Val's family, and it's all about quality. It's about maintaining her dignity, her independence, and allowing her to stay at home with the quality she deserves for the time she's got left. It's about making memories with those that she loves around her. I know this better than anyone because Val's my mum.
Thank you, and thanks for sharing that story. I think quite emotional. Everybody, I'm sure we're watching that would find it. Is there anything further you would like to add?
No, nothing to add. We're just here to plead for the recognition of community services and hopefully to get support from the board around how we can progress that in the future.
I think it's quite powerful that you're sharing the video with us to show the interventions and support that's been there for your mum. So thanks very much, and also thank your mum, if you would, for sharing her story with us. Okay, thank you. Is there any questions from members? Almost out.
Yeah. I just had a quick question. Thank you so much. You've been very brave to share this personal story as well, but equally giving up that understanding. So thank you so much. Once the service is great and you have been really dedicated and committed to this frailty journey, as it were, what are the key challenges that you might have faced, which perhaps at the board level or at our level we can help more? Just quick 1 or 2 challenges which you think could make it even better or easier for me?
I think it's a lot around about public awareness. It's about navigation. I think some of the platform that the Older Person Pathway would give us is that platform to share what is available. I still think often people are not fully aware, so they go through the traditional pathway. So I think there's a lot of work that we could be doing, and like I say, we'd align the pathway around public awareness of alternatives, their rights. Having been a palliative care nurse as well in the past, people don't know what is available to them to stop them coming in, so they think that's the only option that they've got. So it's how do we do that? How do we standardise that access to everybody? And again, I think the pathway could potentially, and as well with the promise that the left shift into community can help us to develop those services forward. So we know we can do it, but we know there's a lot of people that we're not meeting as well. So we need to find a way to make sure we widen our net to capture people that we are missing at the moment. The challenges you see, Carol.
Bring in Nicola and then please.
No, I just want to thank you, Joe, for your story. It's so powerful, and it takes a lot to hold it together listening to that. But, you know, I think your mother would represent a huge amount of the population in terms of what their wishes are. And I know how important it is to kind of get those discussions and understand the family. And I think part of the older person's pathway and some of the other work we're doing is how do we assess what is the real need out there versus, you know, what we do sometimes in a reactive situation. And, you know, I don't know, and I know Catherine through the, you know, the CRTs in each of the areas is, you know, do you feel as capacity is the issue there, or is it more about the public awareness and patient awareness?
Some of it's capacity, and I don't think it's always public awareness. I think it's professional awareness as well. The GPs are not always aware of us, and as much as we try and engage with our GP colleagues as much as we can, you know, with locum cover, etc., and new appointments is really hard. And I certainly still meet teams. You know, we do a lot of training in ED, lots of teams that don't know that we exist or what we can provide, or maybe the risk they perceive, but the risk we're willing to carry to keep these people at home. And I think it's hard to get that across to everybody. There is a capacity issue, I suppose. You know, we're working with quite sick people in the community, so that can make it challenging at times as to how many risks we're willing to take at a consultant level.
But I think the older person pathway will help us to address some of that recognition of capacity. And I think even now is bringing those MDTs and the primary care teams and the place-based care approach much closer together to make sure that everybody's doing what's only unique to them. And I think that's what we're trying to review as well via frailty, of ensuring that the rapid frailty element is only what needs to be done by rapid frailty. So I think there's that MDT approach, but again, we're on that journey with place-based care, etc., that we bring those MDTs together.
Tracy, please.
Thanks, Jay. Thanks for sharing the story, and I'm so sorry for your loss. But really grateful for the legacy that you've shared with us in terms of what your mum is able to educate and share that awareness with us all. I think for me, it's a really tiny thing, but it really matters. You said within your account the importance of focusing on her life and care. And I just think it's so wonderful that you put life first, that it isn't all just centred around the care, but actually it's a person first, and the care they need is just part of that. Absolutely. So I just thought that was beautiful, and it was the whole thing was touching, but that for me just showed that where your motivation is and where the ethics and the morality of your service is absolutely in the right place. So huge thank you.
And I think often we get, there's a label to people who've done advanced care planning or DNA CPRs that almost ready to die. That isn't the case. She was ready to live. Yeah. Do you know? So I think it is about living with quality rather than living in the wrong area. So
I think being able to assess somebody in their own house, you see that life much more because you see where they're living, how they're living. You see pictures of how they used to be. So you
beautiful pictures as well.
Yes, they were everywhere in the house. The pictures.
Thank you. Amazing.
Can I just say as well, I missed the last slide because I was looking at yourself because I was away. It was your mum. So here to have sat here, having lost your mum and as well, and explained to us, that's even more, I think, poignant. So thank you very much. Really appreciate it. Is there any other questions around the board? Seema, please.
Just again to thank both of you, Kath and Joe, and this story. And I know there are many other people out there that you could have described this kind of care about, but it powerfully demonstrates the positive impact you can make when you deliver services that are designed around what matters to people and their needs, and not expecting them to try and navigate what sometimes is experienced as very fragmented services. And what we can see is people having multiple assessments that they don't necessarily need, to have multiple handoffs between different services that gets in the way of good care and experience, and delays sometimes in accessing the right expertise, your expertise. And so the Older People's Pathway absolutely seeks to tackle these issues. So thanks again for sharing the story and the great work that you do as a team.
David?
going to say thank you for this. The story is very familiar to me because the team gave a lot of support to my mum last year and I went up to the end. So it's good to sort of see that again and just say thank you.
Okay. There's no other comments or questions from me. So again, thank you for joining us and presenting us. It's really appreciated.
Thank you for giving us the opportunity.
Thank you. Thanks. Thanks, Liz.
Thank you. So following on from that, next item is the same area around the older person's pathway transformation, which was just referenced. So Leanne is going to present this to us, please.
I feel like saying what they said as the introduction to that, Chair, but I think it's fair to say that we couldn't have asked for a more compelling introduction as to why this change is required. And I think, you know, important to share, if the divisional nurse for one of our services feel that this is suitable, then it's absolutely the standard that we should expect. I've been fortunate enough to have been involved in a lot of transformation around healthcare delivery in my career. But I have to say, listening to some of this, none would make me prouder than to get this over the line working with the rest of the board, I think, to implement it really. So today I'm seeking board approval for a 6-month pilot of a revised older person's pathway at Ysbyty Ysbryd Fawr to include the establishment of an acute frailty unit from October 26th. I'm also asking board to note that this is a test of change with a learning to inform future development of the wider older person's pathway across the health board, because it is a very significant change. We've had discussions about this both with our Welsh Government colleagues and NHSP&I, as well as in board development sessions. So I think we're all aware of the scale of change that this represents. So why we're bringing this change forward, you know, the starting point is simple. We've had it covered off and the story tells it much better than I will describe in the presentation to board today. Our population is ageing, frailty, multimorbidity and complexity is increasing. And at the same time, our current system, in spite of our best efforts of our teams, responds too late, it relies too heavily on traditional hospital admission and creates unnecessary delays for frail people and their families as well. And if we're serious about improving outcomes and reducing harm from deconditioning and supporting people to live independently for longer, we need a different model. And the proposal represents a really important step forward for that ambition. I think important to share, it aligns with national policy, it reflects a home first approach, it builds on the direction that a long-standing strategy and policy that we've had around clinical futures and that care closer to home element of our clinical future strategy. Our vision is an integrated pathway that supports our older frail patients and people and population to receive the right care in the right place at the right time from the right professional. The pathway places greater emphasis on community support, early frailty identification and avoiding those unnecessary hospital admissions wherever possible that sadly have become the default rather than, I think, sort of the need or necessity. Key components will be a strong place-based care model, and Joe's alluded to that already. A really important element of this will be that single point of access to navigate patients through the system and to ensure that they end in the right place so that we can access not just care but advice, guidance and sort of support maybe from other parties, voluntary sector and local authority partners as well. A rapid specialist frailty assessment, same-day emergency care and acute frailty units, and admission only when specialist inpatient care is genuinely required. The evidence for acute frailty services is compelling. We've got GIRFT recommendations, is a Welsh acute frailty framework, which demonstrates that the evidence is there that shows how outcomes can be improved, length of stay reduced, and most importantly, getting people home sort of as soon as they possibly can to enjoy their lives, as we've seen with VAL. So the proposal for the acute frailty unit will include that early senior clinical decision maker, rapid multidisciplinary assessment, improved coordination of care, earlier discharge planning and improved admission avoidance. And most importantly, it will ensure our inpatient beds are reserved for those who only truly need them. And obviously that links with the conversation that we've had earlier. So why Ysbyty Ysbryd Fawr and sort of why a pilot? I think The answer to that is it is the most appropriate place on the basis of the options that we have to test the model at manageable scale. Many of the building blocks for a successful model exist there already. It's got an established frailty expertise. Kath, who you've seen, is a very passionate advocate of that and is embedded in sort of a YYF. We've got strong care of the elderly leadership, a mature integrated working with our local authority partners across one footprint. And I think it exists in patient flows that align well with frailty criteria, as well as our estate configuration being suitable for implementation. Starting with a single site pilot allows us to learn safely, evaluate rigorously, and refine the model before considering wider rollout. We've tested this, as you'll be aware from previous conversations on this, by looking at our take across the system for a period of time and done a desktop audit. I know some of the questions we've had on that, is that sufficient? But when you look at the evidence base from the national standards and other models where this actually has been implemented, that number, the impact that we've or outcomes that we think can be achieved by caring for people in the community is consistent with the outcome of our desktop audit. But equally important, given that this is a pilot, it gives us a further opportunity just to test the numbers from a modelling perspective. Our modelling also shows that older frail people account for more than half attendances at Ysbyty Ystrad Fawr, and there's sufficient demand to sustain the model. And as I've outlined already, sort of the team are pretty well set up in terms of that frailty. Success will not be measured by the opening of an acute frailty unit. We will ensure that's tracked by better outcomes to include more same day and earlier discharges, reduced length of stay, more patients receiving comprehensive geriatric assessment within 24 hours, improved patient and care experience, increased admission avoidance, and improved utilisation of our community pathways. And these measures will form part of a structured evaluation throughout the pilot period. We've had lots of questions and engagement from the clinical teams, particularly at YYF. I think really important to share with the board and Seema and myself, who are hand in hand on this particular journey, welcome that. They reflect exactly the level of clinical scrutiny that we would expect and engagement that we would want to help us design and shape the pilot and learn from the pilot. I know change is daunting for our staff, and it's our responsibility, I think, to guide and support people through that change. Important also to share, no final workforce model has been agreed, no staffing changes are triggered by today's decision, and any future changes will be developed through our partnership arrangements and formal engagement processes if required. As I've said, I think the story shows what a compelling and passionate team we have in terms of implementation of the pathway. So board approval today enables the pilot, and then the next phase of the detailed co-design sort of will follow. It does not predetermine. I think it's really important to share longer term service decisions at this point. We will need to come back to it when we've done the learning from the pilot, refined it, come back with an evidence base around what that actually means across the system. Really important, I think, to reinforce at the centre of this proposal is the experience of our older, more frail, vulnerable population and people. Our patient story highlights that, and it is exactly what this pathway seeks to achieve at scale for our population. We need a more coordinated, proactive and person-centred approach that allows the normal story to be VALS, not the exception to the rule at the minute. So, Chair and Board, this is not a decision around full implementation. It's a decision to test whether our belief that a better model of care can improve outcomes for some of our most vulnerable patients while supporting the wider system. Doing nothing is not a neutral option. Our current system is under significant pressure, and we know, most importantly, there are opportunities to deliver better outcomes for patients. So just in summary, just ask the board to approve the 6-month pilot of the revised clinical pathway and acute frailty unit at YYF from October 26, and note that the pilot will have rigorous monitoring evaluation and will be used to inform future decisions regarding the person's pathway. Thank you.
Okay, thank you again. And just comes to the board and comments and questions. Penny, first, please.
Yeah, great idea. I'm just so behind it, especially coming from a local authority that has so many older population. I just want to who will service YYF? Who will the service users be? Will it be local, or will it extend, to other areas? And is this a kind of platform? I think you did say the word platform, with a view to extending this in other parts of the Iron Bevan Health Board.
Okay, I'm going to take a minute through. Paul, I think, did you indicate? Sorry. No, I think it was Helen and then Helen, was it? I think I'm right in that order, so.
Thank you very much, Chair. Just obviously very supportive of this, and I think the story we've had has already really demonstrate how it works in practice, which, looking at slides doesn't actually convey the same story or have the same impact. But I suppose I think you mentioned it almost actually in your last sentence, really taken away from the evaluation of this, and obviously you're going to be doing that from the beginning. And not just at the end, as it says on this, so that if it is successful and we want to roll it out, we're not having to wait too long again to sort it out from there. So it's just, hopefully we can move on, and this will just be the initial pilot, and then be an example for further areas you may want to develop.
Thanks, Helen.
Yeah, similarly, I think it's a really significant pilot. Happy to support it, and I think it's got real exciting potential for the whole of our population. I just wanted to pick up on the point that was raised in the brilliant presentation that we had around some engagement from primary care. So, what further work does need to happen there? And secondly, in the report, there's some outline of risks, and it says one of the greatest risks is around workforce shortages in the community. But I think on the flip side, it also says there's new roles and ways of working, but part of that is obviously contingent on things outside of our control. So I wanted to understand the conversations that were going on there.
Okay, I'll go with my three now. So it will be local. We're trying to retain the locality-based care closer to home, because the success of this will be people accessing services in their own local communities. And I think that integration with local authorities, particularly in Caerphilly, I think will be really important for us. They're absolutely, the proposal will be that because we've got a test bed, really, I guess, that as soon as we possibly can, we will roll that out to other sites, because we want the same benefits to manifest across the whole of our system, but we need to make sure that we do the learning in a controlled fashion, I think, for spread and scale. And you can feel, I think, sort of the vibe and the passion in the room around wanting to do this, and the commitment from us. So there's definitely a commitment that we will do this as soon as we possibly can, when we're clear about impact reconfiguration, and we've done due diligence with our teams and our local communities around what that change means, really, which I think covers off probably Helen's and Penny's point. Engagement from primary care, we've had GPs in the room as part of the pathway change, actually, and the bit that I think we need to capitalise on now as part of the pilot change is on place-based care, things like the 0.5 sort of highest risk of populations at risk and the rise in risk patients. How are we coordinating or sort of identifying those patients as part of the pathway? So good engagement from primary care, absolutely on board. I think more to be done, definitely. The bit that we absolutely have to nail, though, I think, is helping our GP colleagues, because some of this is about ease of access and navigation. So our single point of access, our SPOA model, our navigation model, will be critical to success. It's a very significant enabler for this, because we have to make it easy for GPs to do the right thing and to get patients where they need to go. So I think that is a really important point. In terms of the workforce issues, we have an idea at the moment. We have an idea from the modelling that's being done. And the reality is some of our community-based resources and community workforce is picking up work. I'm going to use picking up work as a result of the patient having gone through the hospital system. So we're almost increasing the demand as well on those teams because of the current configuration. So part of the work that the pilot will do is, what does it do to overarching workloads of those community teams? There absolutely does need to be a shift left in terms of our hospital-based, I think potentially sort of COTI, care of the elderly doctors, into frailty, but I think that's actually much more attractive. At YYF in particular, only half of our consultant workforce is substantive. So we need to bring forward a new model that gives us the best chance of recruitment that I think would allow this shift to happen. But the pilot will allow us to do that learning because we haven't got all of the answers now. We're incredibly curious about what that looks like. So very keen to and committed to, I think, to do the learning as rapidly as we can to embed it and bring forward a more formal change to board. If there's anything you would
Yeah, I think just to Helen's point about workforce, we are and backing Leanne's comment about we are creating demand at the moment with the way that some of our patients experience care. And once you get that early identification of frailty, care being delivered in the right by the right people, you reduce those multiple assessments and handoffs, and then you don't necessarily need the type of workforce that are having to rise up to that demand. And I just wanted to add in terms of the evaluation, luckily we're not the first pioneers going forwards in this work, and we've linked in really strongly with, Leanne mentioned the Welsh Acute Frailty Service national team and the framework that they've developed, which has metrics attached to it. We've also got the GIRFT operational standards for emergency care with good metrics that we can follow, and we've linked in with other places that have done this work already and have seen substantial improvements and impact that we would be seeking to mirror in terms of reduced length of stay, increased discharges, the reduction of people going into care homes. And so there are many opportunities for us to measure the impact.
Thank you. Neil, please.
Thank you. Yes. Thank you, Chair. Leanne, that's actually answered my questions in your expansion, so thank you for that. I'd just like to say I'm very supportive.
Thanks. Online now, we've got Vivek, please.
Thank you, Chair. And thank you, Leanne and Seema, for setting this up. This is well overdue, and I wish it all success. My only little bit was that, you know, it's a pilot and we should be a bit more stubborn with the pilot and push hard on it, because this is one of those things which is a game changer. And even if we have a minor setback, it shouldn't put us off, and we should continue to persevere on this, because it's a learning experience and it will serve our vast community hugely in years to come. Thank you.
I don't think you could probably get two more stubborn people than Seema and myself, Vivek. So full commitment to not stepping back or shying away from challenges that will undoubtedly come forward as part of the pilot and part of the learning. Change is difficult for our staff. You know, we've talked about it before. It's natural for people to feel uncertain. But there is no question when we put patients at the heart of the changes that we are undertaking, and our populations as well, actually, and their families, that I think that will require us absolutely not to do that. And I know that we're both fully committed to
that. Somebody else has indicated, sorry, thus everybody is content. The board is asked to approve the proposed pilot to implement the revised clinical pathway at YYF, establish an acute frailty unit from October 2026, and note the test and change associated learning, which will inform the future transformation, development and redesign of the older person's pathway. Is the board all content to agree? Yeah, that's clear. Okay, thank you very much. On to the next item then, which is the chair and the chief executive did. So just to put on the record, it'd be helpful for me just to set out that earlier this morning in private session, the board discussed a number of items which were not suitable to be in the public domain, but the board did approve the following areas. First of all, a rapid release protocol to support timely handover of patients from ambulances into hospital, in line with the board's previously agreed urgent and emergency care improvement plan. The board also agreed a planned care recovery plan for 2026-2027, setting out the actions required to eliminate the 104-week waits, reduce the 78-week waits in key specialties, and achieving an 8-week diagnostic position, supported by investment of up to £28.6 million across recovery, diagnostics, transformation schemes for submission to the Welsh Government. The board also agreed a 3-year financial recovery plan, setting up the route to recurrent financial balance by the end of 2028-2029 through an updated opportunities pipeline. with over £107 million worth of savings, including delivery of the £45 million savings required within 2026-2027. We also agreed the South East Wales Regional Orthopaedic Plan and Llantrwst Health Park pipeline and full business case, supporting a regional approach to reducing long waits, addressing demand and capacity challenges, and progressing sustainable, high volume, low complexity elective orthopaedic hub, subject to Welsh Government funding approval. And lastly, we also agreed the transforming access to medicine South East Wales hub full business case, supporting the development of a regional aseptic medicine manufacturing hub to improve the resilience, regulatory compliance, workforce sustainability and supply reliability, and authorising submission to the Welsh Government for final approval. I'll also just very quickly say that in the last couple of weeks, I've attended a number of meetings with the chairs and the Welsh Government. Grateful to the Vice Chair who stood in for a ministerial meeting I wasn't able to make when I was away. But also there's been some engagement over the last week as well with Welsh Government officials and positive feedback on the whole in terms of some of the areas of improvement the board needed to make. And our work has been quite intensive, and just like to thank all the executive team and the chief exec for the work that's been ongoing there. And lastly to say, last week I attended two events. One was the nursing conference last Wednesday and the staff awards on Friday. And I thought both not only were excellently supported and organised by the health board, but also seeing some of those case studies and some of the interventions that our staff have done to help individuals, and hearing some of those stories, both on the Wednesday conference, but also at the staff awards, I think was exceptional. It's important to recognise, and it was pleasing to see that so many of the board were able to make that and take part in the overall event. So that's my very quick update before I hand over to the chief executive.
Yeah, thanks, Jay, and follows on some of the points you've made. So it's been a really intense couple of months at the first quarter of the financial year, with particular kind of targeted efforts on the emergency care plan and the Handover 45. As the Chair mentioned, we had some further detailed discussions this morning, but this has been a dominant priority for us, and we are making progress, albeit we know we need some step change in order to make further impact. And this week, the teams are really busy on our multi-agency discharge events, again trying to focus on that part of the system where we need people to be home where appropriate and to make sure we can expedite those. We've also made some really good progress on the financial agenda. So got a very challenging financial context, but we committed to fully identify our £45 million savings programme, which we have done now with all of those being green or amber, and continuously making more of those savings in the green category where there's a greater level of confidence. So we are also now going to be talking in the agenda around that 3-year roadmap to sustainability. So we talked about earlier. So made the two commitments we gave to Welsh Government in our last escalation meeting, we will have met by the end of this week. And then in addition to that, we had requests at the end of June, all health boards did, in terms of how we would potentially utilise the 145 million that's been allocated by Welsh Government for the planned care priorities. And we've all had to submit, particularly around 104-week waits elimination. Can we go further? Diagnostics as well. So again, this was discussed in more detail in the private session, but Leanne and the team have been working exceptionally hard, along with planning, finance and workforce colleagues, to try to get as much of this detail into the submission, which will go up by the end of this week. And again, really committed to take advantage of the opportunity to reduce these waiting lists, both looking at local solutions as well as regional solutions with our other health boards. And in addition to that, we had a really helpful session on place-based care over the last few weeks with Tracy and Leanne, particularly with some key stakeholders, looking at how we can increase the pace of delivery around some of our place-based care work. There's some really good work being done on local communities and how we can bring that to life and demonstrate what this looks like going into the next year. And I know we've got some targeted time to discuss this in the coming months on the board as this programme progresses, but so important that we put that focus on community and prevention, as well as the kind of acute side of care. And linked to that, the Chair mentioned there was a meeting with the Health Minister, the Deputy Health Ministers, with chairs and chief execs. And again, what was really particularly refreshing is that focus around prevention, public health, and making sure health is seen as kind of everybody's business. So really encouraging kind of focus on this particular part of the agenda. Andrew mentioned the staff awards of the nursing conference. It was a really good uplifting week last week to be able to celebrate some of the great work going on across the organisation, despite the challenging context many of our staff work on. It really was a celebratory event, particularly on Friday, where we celebrated many staff. I'm looking forward to the AGM this evening as well as an opportunity to kind of share the reflections of last year and our priorities for the remainder of this year. So that's true.
Okay, thank you. Always just happy to note the updates from both myself and the Chief Exec. We'll move on to the next item in 5.1, which is the financial management and procurement section. And it's in two parts. So the first part is month 3, 2026-2027 financial performance report. Please present. Please, Andrew.
So the report included is the financial performance at the end of June 26. The dashboard identifies a revenue position of year-to-date of £40 million deficit, which is in line with the plan. We're holding a forecast deficit of £41 million in line with plan as well. In terms of capital, we spent £7 million of the £32 million allocation we've got, which is 22% compared to 25% time profile. So that's very positive in terms of capital spend profile. Our public sector payment policy is achieving 97%, which is above the 95% target. So that's positive. Savings year to date are £5 million against the £45 million forecast plan, and I'll say a bit more about that in a moment. The summary run chart included shows the profile for the year of performance year to date and expected. Of note, we have been asked to reconsider by Welsh Government our profile of Welsh risk pool presentation in the financials, so we'll reconsider that and look at that. But that may improve. That will have an impact on our run rate and potentially change the plan, but not full year forecast. So that's something I'll come back to next meeting. In terms of overview of the position, our income, particularly from a revenue perspective, includes anticipated income for both ESR, system funding and digital funding, which are the more risky elements. We've had positive feedback now that ESR will be funded. Digital funding, we're just working through now what that means in terms of some recent communications on the EPIF funding and the HCW. That's a figure of about £3 million. We are expecting a significant element of that, but we need to just nail that down. So that's the income position there. Pay spend and non-pay spend is broadly stable and in line with the plan, but we are expecting a significant downturn in both those in quarter 3 and quarter 4 to match our delivery of savings profile. Savings, so we have de-risked the plan and identified £45 million worth of savings now against our annual plan target. £34 million at divisional level, about 50% of that is recurrent and the balance non-recurrent. So we do need to look at our non-recurrent levels and try and improve those. £11 million linked to the Value and Sustainability Board work streams. So that cuts into £30 million green, £4 million delegated schemes at an amber level, and £11 million amber at the work stream level. In terms of risks, it is important to note that we still have to land the plan. We have some emerging operational risks that are included in the report, approximately £4 million. We're expecting to mitigate and take actions on those. And then 2 others of note is the resident doctors contract and the joint committee level of savings that were expected and agreed through the plan that need to be firmed up. Overall, we've obviously got to deliver our savings levels, but we might have to find additional mitigations and savings to actually maintain the delivery of our £41 million deficit. And if we can go better than that, we obviously will do. We're holding reserves of £22 million, and that'll be the subject of the next paper. Just to note the addition of what you've just said, Andrew, around the financial recovery plan and the opportunities pipeline that are going to be reported to Welsh Government shortly.
Thanks. Any comments or questions at this point? No. Everybody's content? We move on to the second part. Just the budget delegation 2026-2027 phase 2.
Yeah, so this report is a follow-on from the original budget setting that was agreed in March as part of our best practice governance approach. We set a budget plan aligned to the annual plan or the INTP, and those budgets were delegated for performance management start of the year. At that point, we held minimal reserves, and those reserves were aligned with the costs identified either as cost pressures or investment priorities as part of that annual plan. We do not have a contingency reserve. At quarter one, there's a review of our current income levels because they move every month with Welsh Government. We got £1.9 billion funding identified, and then this paper identifies consideration of how we would apply those reserves to plan priorities and cost pressures. Now we've seen 3 months of the actuals emerging through our financial and service plans. To note, we continue to forecast a deficit, so there is not enough reserves to balance all the costs we're expecting in the year. However, the table does identify a recommended approach for delegations and describes various mechanisms and triggers to delegate by the Chief Exec throughout the year going forward. The board is asked to note this for assurance as a secondary follow-up to our initial budget setting.
Thank you. Any comments or questions on the second part of the board, please?
Is there anything, Rob, that the board can do to assist you with ensuring that ultimately we'll achieve financial balance?
Other than supporting proposals that may be challenging moving forward in the future, at this point in time, the focus is very much this year. What the budget delegations may enable us to do is potentially set control totals we discussed earlier. But again, the focus has got to be living within budgets. I think from a board perspective, we are likely, particularly in the future 2 years, to have some challenging decisions to be considered, and obviously considered and a measured response to those proposals as they come forward.
Thank you. I think we reflected that the financial position, certainly for this year, in terms of the identified savings that has obviously moved on a pace in recent weeks and the last couple of months, which gives a little bit more confidence in terms of delivery. Overall, there's the 3-year plan and the 3-year route back to balance is key for what Welsh Government is asking us, and obviously for sustainability for Health Board. But it is a positive shift with the weeks ago. I know in the last few days we sent this information out into Welsh Government, to PNI as well, so they are aware of the progress that is being made for financial recovery. If there's no further comments or questions, then we'll ask to note the 2 reports assurance. We all content and happy with this?
Yep.
On the next one then, which is the programme plan K and the programme review. Anna, please.
Thank you, Chair. So yeah, just to remind colleagues, in May, at our May meeting, the board approved a delivery framework that set out the transformation or priority programmes that we needed to be established or continued and refreshed that would support driving delivery of the plan and elements of the strategy. And as part of that paper we agreed in May, we did set out a schedule of when deep dives on each of those programmes would come forward to board to enable a bit of a greater understanding of what was happening in those. So it's the turn of the planned care programme. You'll see both in the cover paper and in the main report kind of a schematic that sort of just reminds colleagues of those 6 key transformation programmes, and then indeed the enabling plans and programmes that support it. So with obviously the red around planned care, because where we're focusing now. I guess it's important to say in our in-committee meeting, and as alluded to, we have done and are doing some work on the planned care plan in light of the refreshed national plan around pillars, and we will obviously need to refresh our plan depending on the response we get to our requests for investment, whether we get all, some, or whatever permutation of the investment we've asked for. So I think it's important to say this deep dive kind of looks at the current programme, but recognising already we have started to remap that against the pillars, the 3 pillars of that have been set out in the new Welsh Government framing, and indeed will update in line with, as I said, any investment that we secure. So I just think that, I'm going to be talking about work streams that we will be reframing as we go forward. So I appreciate it's quite a lengthy paper, so outside of the meeting, happy to take feedback on whether it's kind of too much or too little detail in terms of what colleagues want on deep dives. But the paper, the substantive paper on the cover paper does give quite a lot of information on context for planned care. So it does demonstrate how referrals have been increasing, often given the kind of reference point of pre-COVID. So you can see that our referrals have gone up per 100,000 population. We'll now well exceeding the pre-COVID levels, although you can see it took a while to get back to there. You'll also see through the early context section of the plan that our activity, that the amount of work we're doing is significantly more across a number of areas. New outpatient appointments, follow-up appointments, treatments is significantly more than pre-COVID, and has indeed been growing year on year. So often, we'll come on to talk about the performance report later, we talk about the performance outturns, how many people are waiting, what's the efficiency of productivity, or how are we on certain metrics. But this kind of gives you a bit of a context for that in terms of the amount of work that's being done, and kind of how that sort of manifests is in that first sort of block chart on the actual total numbers on our waiting list. So pre-COVID, we had about 76,000, as we call open pathways on the waiting list, and that went up significantly. As you can see, just choosing September 25 as a point, but has gone down to just over 100,000, just over 101,000 actually at the start of the year. So massive decrease, but still significantly higher than pre-COVID. So it's just, I thought before you get into the detail of what's within the plan, that is quite a helpful, important context. The report then sets out how the planned care programme for this year builds on previous year, and it summarises some of the progress made last year, and then sets out the current framing of the planned care programme, as I said already, which we will remap and relook at in line with the new pillars. But for now, we've been framing it around demand management. So what are the actions, initiatives, or insight we need to look at to help either stem the flow of referrals or ensure that those referrals we get are the most appropriate. So the kind of deliverables and initiatives we're looking at under demand management are building on the interface GP model, so how we're using GPs to review referrals, and the use of health pathways to determine requirements, for example, sorts of diagnostics patients should have had before they're referred, and also some key kind of enabling elements in digital, for example, e-advice, which will enable two-way communication between referrer and secondary care consultant to properly determine, is a referral necessary. So there's a lot of activity under that kind of work stream for us, as well as how we're using the data and doing some deep dives into the data to look at any variation between referral rates. And we've got that at GP cluster level, because it's important we're checking if there are outliers in terms of a higher number of referral rates per GP that practice you'd expect, but equally lower numbers because we want appropriate referrals. So the report shares the metrics and updates on some of those key areas. From an outpatient's perspective, we're looking at this through a couple of lenses in terms of looking at the efficiency opportunities. Whilst progress has been made, you'll see, and we look at that every time in the performance report, we still have variability in between specialties, but we do look at DNA, CNA rates and SOS and PIFU, which is the pathways put patients on to try and reduce the need for follow-ups. We do have a large follow-up waiting list. But over and above that, in terms of the transformational areas we've been looking at, the development of different models, so super clinics or mega clinics, whether these be in person or virtual, and some examples are given in the paper of those and the yields that they are having. Third area then is about theatres optimisation, and again the paper summarises the key metrics in that respect, and again we look at these in the context of the performance report. And the real focus, we know that the theatres is also looks both ways. It looks into this plan care work and looks into the VSB work, and we know there are opportunities to improve both the efficiency of the theatres per list, but also where we're doing activity. So a big part of the work for this year is looking at how we can take activity out of theatres and re-provide in a non-theatre environment, whether that be a treatment room, you know, any sort of treatment room really. So there's a significant amount of work happening there, as well as looking at the development of a surgical hub at YYF as part of the national programme. And then finally, the paper just summarises some of the key, what we call kind of enablers in this space, whether they be from a digital perspective, work that's happening around strengthening our approach to validation through the validation strategy, both administrative and clinical validation. I can give a couple of examples of how we're linking Paul and his team on some of the digital enablers to support plan care. It clearly links in with the regional work we've talked about previously, and also the development and ongoing training associated with the Plan Care Academy, which is really supporting upskilling, testing, refreshing operational colleagues in best practice around scheduling and those sorts of examples for getting best use out of those lists. Appreciate there's a lot of detail and there's metrics and risks within the paper, but I think we've made, hopefully you'll see from the report, significant progress has been made, both in some of the efficiency and productivity opportunities and the actual transformation. Still an awful lot to go at that we are confident and hopeful will be kind of given a support and a lift through any additional monies that we'll receive on the back of the plan Leanne talked about earlier. So I'll pause there, but happy to take any questions.
Okay, thank you, Hannah. Any questions, comments on the report? Please.
Yeah, just a couple of comments on the advice. That really looks like it could be a real game changer for the efficiency. So really welcome that. I noticed in terms of, I think the mega surgeries, or mega clinics, there's mooted about moving to an algorithmic approval process and prioritising people across waiting lists. So I just wanted some assurance about how that works in terms of patients for whom time and risk is more significant. So how do we ensure that we're still prioritising people in a safe manner if we do that shift?
Yeah.
1 second.
Yeah, sorry.
Bring in Neil next, please.
Yeah, thank you for this. What are the outcome measures apart from waiting times that we should be looking or hoping to see as a result of this?
No other comments, questions, no? So thanks, Hannah.
Okay, thank you. Yeah, and so the advice is really, really important. And we're working closely with Paul and his team to try and get that in place ASAP. And there's an element of development, there's a lot of technical stuff that Paul's team will support, but then there'll be a bit of training development just to get that to test, do both the training and development to get the awareness both in secondary and primary care, and then sort of test those models. But it is seen as absolutely key and we're quite excited about that. In terms of the mega clinics, I don't know if I'll check I've understood the question, but there are models of care where patients can be cohorted according to what the referrals are saying, so whether that be general surgery, query, got gallbladder problems, or where they can group them together in order to, so they're not always necessarily, it's important on this one, they're not always necessarily taken in order because they're mobilising an MDT to deal with kind of a set of patients that have potentially similar issues, and behind it making sure that the radiology and the diagnostics is there. They can take other forms as well. I mean, speaking to Rhiannon Reynolds from ophthalmology, they've done a virtual mega clinic where the multidisciplinary goes in. They have diagnostics already through the photos they have of the eyes. So different models. I think in that clinic we only saw over 60 patients. So there are a few models for that. There is work that we want to start to have a look at the prioritisation, how we're prioritising, and it doesn't really come through in the paper, but also started to look at underneath the waiting lists in terms of, are there any are our actions having any undesired consequences? I think this is to a point a bit as well, Neil, in terms of inequalities. So are we making sure that access isn't just so the timeliness? So we're looking at children on waiting lists, but also looking at from different kind of areas of deprivation on waiting lists to make sure people aren't waiting longer in certain areas than they are in some. So we're taking a bit of a multi-pronged approach to that. In terms of outcome measures, I think it's a really good question. Whenever we talk about planned care, we talk about sort of activity and widgets and performance, which is normally time and or efficiency, productivity. We have raised, there's work happening at a national level around sort of outcomes framework and how we can get some of these outcome measures into planned care, but I don't think we've quite got to a place with that yet. But we do track, and I'm sure Jenny and others will come in, but in terms of incidents, for example, work was done when we noticed there was some reportable incidents around patients going blind or losing sight for ophthalmology. So a different approach was then taken to how do we sort of sense check and do some validation of that list to make sure that we're kind of not missing the point in terms of what we're measuring. But I think it's something we need to do more work on collectively in terms of the outcomes, because what we're trying to essentially do here is to people get timely access, and that's made up of a whole load of things, only seeing patients when we need to, all the different mechanisms that I've talked about, but it is about timeliness of access in order to improve outcomes in its broadest sense, and there's a patient experience element to that. But I do think we need to probably do some work on planned care specific outcomes.
Okay. I'll just ask one question if I could. Following that point actually around, do we have a track, or is there a way of when we are speeding up of the work through the backlog, for example, of people waiting for operations, etc., about what difference it makes to stopping people attending hospital? To give you an example, I had my gallbladder out, but in the time I was waiting for that, which actually wasn't too long a period, but I was admitted to hospital on one occasion. On another occasion, I attended hospital, but I was sent home within 24 hours the following day and never left A&E. But some of these, while people are waiting for these procedures, they quite often come into the system because of other effects from waiting. I just wondered, is there any way of noting that? Because sometimes maybe somebody's been waiting 2 years. I give another personal example I'm aware of elsewhere in Wales, where a lady who actually works for one of the health boards, she was on sick and ill for quite some time because she was waiting for a very complex hip operation because it wasn't straightforward. But actually, between the local authority, I had to step in and provide social care to her at home. We had to provide a commode downstairs in the house because she wasn't able to access her bedroom upstairs. And this lady was of working age, and as I say, actually worked for one of the health boards as a nurse. But that lady had to attend, I think I might say, almost a dozen times to hospital in the 2-year period because of pain management and base issues. So sometimes I suppose in addressing the backlog, a further benefit is actually that hospital avoidance, or just the avoidance of contact with the health service overall. And I just wondered, is there any way of tracking some of that
Yeah, absolutely. Leanne's got a hand up as well, but there's that element, and then there's sometimes from a GP perspective, you might be thinking you're going to wait. You might be referred to multiple pathways, or referred to things. So there's the benefit. As well, the obvious benefit being the patient is in pain for a lesser amount of time. In terms of system-wide benefits from multiple pathways, and or, as you said, patients coming in as they're waiting. But I can see Leanne had a hand up.
Yeah, I do think we need to become more sophisticated in our assessment of sort of outcome measures around palliative care in particular. So timely access tends to be the one that we monitor. So I know that the teams are chomping at the bit for patient-reported outcomes, because it doesn't matter. You can go through in 2 weeks. If your outcome is poor, that is not good. That's clearly not what we're aiming for. So we do have pockets where teams have had a go, if you like, at those patient-reported outcomes, pain, functional ability. I think that feedback from the teams, I think, particularly orthopedics related, I think believe that that's a considerable sort of game changer for us, really. I think there are some other metrics from an outcome perspective, readmission, complication rates, back to your point around, number of times they go back and forth the GP sort of whilst they're waiting on the list. I think there's something for us to do about improving, and it's one of the things that we will have to do, I think, around the PMO from the planned care recovery perspective this year, is come up with a more sophisticated dashboard or set of metrics that shows in the round how we're doing on planned care, because if we can resolve some of these things, then I think it brings a benefit not only to our patients, but across the wider system.
Just completely echo what Leanne said about patient-reported outcome measures and building that into our work. There are also systems and organisations where they are looking at tipping into urgent and emergency care because of prolonged waits on a waiting list, and that can help us, if we get it right, to build a picture of what the clinical prioritisation actually is when people are waiting, and how we do treat people in turn. But then if their clinical risk changes and their urgency changes, then we can actually apply that and prevent people actually then becoming sicker whilst they're waiting.
Okay, Helen, please.
Thanks so much. There's obviously quite a lot of work streams in this and lots of different lines of not attack, but lines of things that you want to evaluate. Do we actually have the capacity within your team to do all these things? Or are there digital solutions, or is it such as you've got evaluation of the clinical pathways, which I know it was a Welsh government initiated thing, which do we actually know whether it makes any difference? And I see there's some doubt over funding for it to carry on, and yet we're trying to push it forwards. But has anybody done any work with it here or in other health boards to, is that actually effective or not?
So so it's not just my team. This is predominantly people in the AMS team, with the PMO obviously supporting operationally. Julie Poole, a massive kind of leadership role in this planned care space. But so for example, on health pathways, the local SRO is Owain, who sits in primary care. So the health pathways is really interesting. It was a nationally driven product and approach. And we are collectively, not us in AV, are collectively kind of struggling with that evaluation bit. It's quite difficult we can capture numbers of pathways and we can capture hits when they're loaded, but actually then tracking through the so what is proving challenging. Yeah. So I do think there'll be decisions about funding health pathways going forward, and we know that will be difficult if we're not able to evidence the impact, and about how we, depending on what that future decision may be, how do we not lose both the goodwill lots of clinicians have engaged in developing or adapting national pathways, lose the actual pathway if it's in the system that we no longer access, how we still find mechanisms to build those relationships. So I think we've talked about it and we touched on it. I know in the execs when we talk about planned care, I think we've probably got, and Simon and Leanne, I hope would agree, a bit of work to do just to revisit that clinical engagement interface bit with between on-planned care, but yeah, the health pathway stuff is going to be, we will have to do that, have to be a decision whether we carry on. There has been a national evaluation, but it was quite qualitative in terms of how do you find it using rather than numerical impact. Yeah.
Thank you. Jenny, please.
Just to come back to what Hannah was saying earlier, so we've got an opportunity through resetting our quality. So our quality strategy expires this year. We'll be setting our quality plan for the next 3 to 4 years. And I think one of the things we've done very well is we've looked at the pillars and we've looked at divisions. What we haven't done is align quality to the priority programmes. And there's probably an opportunity as we reset to do some of that in a way that starts to pull out the outcomes, both from a safety and experience, but also a clinical effectiveness perspective as well. So there's a real opportunity as we reset to align better with the programmes. And we're doing some work with a member of Hannah's team on that at the moment.
Jenny, please.
Yeah, just to add to that, so we've got a nationally supported PROM platform, which is patient-reported outcome measures that could tie into these, but there will be a cost to that. That's coming through the value-based healthcare agenda. We've got it embedded in quite a few services, but the request from Welsh Government via WHC a couple of years ago was for full rollout. That will cost us an awful lot of money because of the system requirements, the communication costs, etc., etc. But that was the intention, but that's been put on hold at the moment, largely because of the resource requirements of that.
Thanks.
Going back a little bit, there is a current further evaluation of community health pathways, and OR inputting and colleagues are inputting into that as to what that needs to cover so that we can enhance what's already been done and answer that key question about what do we do in the future.
Penny.
So I don't know if this is the right place to bring it up, but cancer treatments. I just wondered what is being done to bring this in line with the national standards and what we're actually doing about it, because it's quite concerning, I think.
Yeah, I think so. You're right, Penny. We've got some challenges in cancer, which we'll get onto under the performance report. Probably.
As we pick up under that.
Yeah, that's what I thought. Yeah, just
if there's nothing further on this report, the board is asked to note the contents of the attached planned care programme deep dive, and also then to note the requirement to reframe the programme and deliverables in line with the recent national request. So we have intended we note both of them. We're just roughly halfway through the agenda, so we can pause for the company break just for about 5 to 10 minutes before we come back. So we'll just pause the recording online and give us Okay, thank you. We'll continue with the agenda then. Item 5.3, since the 2025-2026 performance reporting and the integrated performance report. So Hannah, first, please.
Thank you, Chair. I'll give just draw out some highlights on the sort of operational performance, then hand to Sarah and then Jenny on the workforce and quality respectively. Just to note, this is the performance in this report. This is the first time as a board, because in May we were looking at the end of last year. So now we are tracking the commitments that we made in our plan for this year. So you might notice some slight differences from the May report. That is due to the fact we're now tracking against our 26-27 plan. The report has as far, the most recent data as far as possible. So in many cases June, but sometimes, as you know, we're on different reporting timelines for some data. The report also introduces, and there's a couple of guidance sheets at the front, which I think in future reports will move to the back, but it it gives some guidance on the interpretation of SPCs, something at a Welsh Government level and NHSP and I. We've always used kind of run charts, but in terms of using some of the icons to help interpret what you're being asked as IMs. If people think it'd be helpful to do any sort of training or more support on the interpretation of those, then we're happy, obviously, to pick that up. So just in terms of the content report, I'm just going to pick out a couple of things under each of the headings. So we're still using the same headings for continuity. From a population health perspective, again, progress, albeit, as I feel like I've said a few times now, we're not complacent. We've got, in terms of vaccinations, we're not a herd immunity. There's lots of focus work, and you can see in the report some of the detailed actions targeting areas of low pickup, but vaccination rates moving in the right direction, albeit we haven't got data for this year yet. Similarly, in sort of best start to life kind of area, the Healthy Child Wales metrics against 6 weeks and 8 weeks are really positive, showing that we are supporting families in those early both examinations, but the conversations that happen around the child. And the diabetes aid care processes is exceeding where our trajectory that we submitted, so that's really positive. And as we heard in a different sort of meeting yesterday, really good supported work through the value-based healthcare team on these processes. In terms of sort of primary care, place-based care, I think it's become a bit of a theme of my updates on this part of the report. We can still see the strong provision that the community is given in terms of activity levels to support the wider system across pharmacy, optometry, and both in terms of PIPs and the common ailment scheme. So really important contribution there, and so that we can take positive assurance from that. Where we probably would spend more time and note is under urgent and emergency care. As we picked up in a number of conversations, this is an important priority for us, noting our escalation, noting the increased and sustained focus, and particularly on handover of ambulances and the Handover 45 initiative. I will say, if you look on the main report on page 26, whilst we've acknowledged both in our in-committee meeting and in our F&P escalation board that we are off track on some of our trajectories, I hope you can see that from the graphs within that report, and within that section on page 26, you can see that we are improving. There are improvements, albeit incremental in some places, but in terms of ambulance handovers, both in terms of the actual numbers of ambulances waiting over 45 minutes, and indeed the total lost hours, which we continue to look at as important as well. So, it's improved for the 5th consecutive month, the total number of lost hours. And an example being that, in June, we lost around 2,000 hours across the system. And June last year, June 25, we'd lost over 2,500. So we are putting those hours back onto the street in order to get back to the community and patients waiting there. So we have seen improvements, but we know there's been challenge, hence some of the conversations and decisions we took earlier in terms of the Handover 45 and the rapid release protocol. We are still got some stubborn metrics around UEC. The wait to be seen and 12 hours has deteriorated slightly, and also pathway care delays. Leanne talked about earlier the work that's happening this week with the multi-agency event, which we would expect to anticipate to yield improvements on pathway of care delays. So I think it's fair to say under the UEC it remains an absolute priority, and we can see signs of improvement, but we're aware through the other conversations, the step change and the actions associated with both the broader UEC plan and the rapid release area we talked about earlier. What we just say as well, we can see some positive improvements around the stroke metrics, really positive in terms of the scanning, direct admission to stroke units, therapy assessments. And these metrics, whilst their time, I think it's to one of your questions earlier, Neil, these are linked with outcomes. The evidence shows that the more timely you move through this pathway, the better outcome you will have. So that was also going to draw out from UEC. From planned care, we talked a lot about it under the early item and under the planned care. So I wasn't going to say too much, but just to draw out the cancer performance, which you asked about earlier, Penny. So the single cancer pathway, the most recent data we have is up till May. As you know, we have till the end of the following month to sort of validate. And it has been challenging, and I'm sure Leanne will come in to provide some context, but 3 tumour sites, particularly the upper and lower GI, neurology, and there is targeted work in those multidisciplinary teams to try to improve compliance there. We have made good progress on the backlog of patients, both patients waiting over 62 and 104 days, and we managed to sustain a really important metric around the time it takes for you to have your diagnosis. So the single cancer pathway performance isn't where we'd like it to be. And yeah, there's lots of work happening, and I'm sure we haven't come on to when I finish this bit. The performance, the planned care performance, we've looked at a plan to improve the number of patients and reduce the number of long waiters. Notwithstanding that, and that we'll see the benefits of that in future reports, no doubt, but notwithstanding that, we are ahead of where we thought we'd be in terms of those numbers. So we were expecting over 600, probably wanted it, but we were in line with our D&C and trajectories expecting over 600 at the end of June. But that was through work of the teams on scheduling and kind of really grip and control bit. That came in at 384. So we've made improvements and therefore are improving our baseline position. We do have some areas of challenge in terms of audiology for both adults and children, and there's some therapies challenges, and they will have featured, and you've seen it earlier in the plan and the ask for additional investment to support improvements in those really important areas. And finally, for mental health, it's important to note the Part 1A and Part 1A and 1B for both adults and children continues to sustain, which is really positive. And whilst clearly more to do, we're starting to see the shoots of improvement that we've been promising in terms of the adult psychological therapies. So up to 55%. We know we've got further to go, but the teams thought they'd be at around 51, so ahead of where they thought they'd be, which is positive. So we expect them to continue on that improvement. The area of challenge under this theme of mental health is around ND, so at just under 48% compliance with those waiting times, which was 26 weeks, just to remind colleagues, and still focused on having no child, nobody waiting over 52 weeks. So there has been some new funding put into that service where looking at new models of care, group work, and different approaches to pathway triage, etc., to improve that. So it remains an area of focus. So appreciate that was quick and there's lots of information, so I'll open it up for questions, but maybe Jan, you'd want to come in on the cancer point, anticipating Penny's question.
Yeah, I think a couple of points I would make, you just to reinforce the things that you've outlined, Hannah. So our PTL is static. We've made good progress in maintaining that total number. I think that's really important in the context of the demand that we're experiencing, Penny. And I think sort of just would highlight that, as is the backlog. And just a reminder for board, so those breach of that performance, can't even talk now, the performance position also doesn't take into account patient choice. So we know from the cancer metrics and demand, any patient choice doesn't adjust the time. And when you look at our backlog, many of the patients sat in our backlog are patient choice. Either they haven't been able to attend or for a variety of different reasons. That said, we know we've got some areas of focus. My SRO for cancer, Arvind, who's our divisional director for CSS, keeps a laser-like focus. I think fair to say, if you know Arvind, you know that's absolutely how he is. We maintain in the position in terms of the diagnosis of the cancer, so that's in excess of 75% and has been consistently for some time. So that early part of the pathway is really, really important. The workforce fragility, you can imagine that we've got very specialist, skilled individuals treating our cancer patients, surgeons and physicians, and sometimes lots of clinical nurse specialists in this area. And sometimes we have significant operational, issues, sickness that then has quite a significant impact for the teams, really. So that gets managed on a sort of tumour site by tumour site basis. But that laser-like focus now is being applied to lower GI and urology in particular, and there's recovery plans that are coming forward in relation to sort of recovery of that position in those areas in particular. The team have also developed a cancer command centre proposal that sat with me, just landed, sat with me for review in terms of what our processes and systems are to manage this. And because we're unhappy with performance, there's an executive deep dive planned, I think, just so that there's that additional scrutiny and executive oversight, so that we're giving it the most serious consideration and thought. What I would also say, though, I think offset against the performance measure is that in excess of 90% of our patients report a very good or good care when they receive that care. So I think the quality and experiential piece alongside that is equally important, but fully committed. We can do better. Not helped really by the fact that, I've referenced it in the plan care conversation earlier, the funding that's been allocated is not for cancer, which doesn't help us really, I think, particularly setting the context of that growth and sort of increasing in referrals in particular.
Thank you. Just check, is there any further comments or questions on the performance report before we move on to the workforce and quality reports? No. If not, can we go on to the workforce report, Sarah, please?
Thank you. I'll take the section as read. I'll just pick up two particular points to note. Contained within the staffing post section, you will see that we have added in there for this board session some work that's been undertaken by my team and Rob's team, identifying our staffing establishment, and that work has been ongoing over the last 12 months or so. And so the establishment that we require as an organisation is just below 14,000 full-time equivalents. And you'll see that then gives us a clear line of sight on our vacancy factor, which is contained within the report. And then just to pick up in terms of a key challenge for us ongoing is monitoring our sickness absence levels. Despite an incredible amount of work focusing on our hotspot areas or our high areas of sickness absence, supporting application of our policy, training, coaching and support for managers, as well as newly developed tools and pocket guides targeting particularly support for staff who are on long-term absence, which drives the majority of our sickness absence. We are seeing sickness absence slightly increase and at a higher level than we were this time last year, particularly for June. So we're just undertaking some analysis work and whether some of the hot weather might have driven some of that absence. to understand how we can keep a focus on that area of work. And we'll be linking in with national programmes of work, because reducing sickness absence is a key programme of the National Workforce Value and Sustainability Programme.
Okay, thank you, Sarah. Is any comments or questions on the workforce element of the report? If not, turn to the quality report, which is for Jen, please.
Yeah, Chair, just a few points for me. I'll take it as read in the main. So just on patient experience, whilst our numbers proportionally to our numbers of interactions is fairly low at 2,600 feedback responses, that's not unusual in patient survey responses. Our satisfaction score is 87%, so above the Orwell's benchmark, and pleasingly, the language that comes through in terms of the narrative, both with what we receive from PALS and through Civica, is compassion, professionalism, that emotional support, and that positive experience. We do know that there are patients who don't have the best experience. Most of our themes relate to waiting times, so that can be on a plan care waiting list or within our urgent and emergency care system, and within that, access to services. We also know that communication is one of our highest scoring areas in terms of negative feedback from PALS. But we do a number of pieces of work to try and address that. So we work very specifically with groups of people who find it hard to access services. We've worked with the neurodiversity community. We're also working currently with LICE and others with our deaf community and hard of hearing community who find it particularly hard to access services. We've got our first patient participation panel for our deaf community in August, so that would be really good. We also do things like have volunteers. We work with the Red Cross. There are a number of mechanisms on our plan care waiting list to respond to patients, but we do know that we don't get it right all of the time with waiting and communication, and we continue to strive to be the best we can be and to make sure we are responding. And PALS provide quite a lot of practical support to patients when they need it. Just a couple of other areas to highlight. Our mortality performance continues to be strong. We're ranked second in Wales within our peer group. We are seeing an improvement in our complaints and concerns management. So listening to people is helping that, because we now have 10 days for early resolution, but we are seeing a significant reduction in our backlog of aged complaints. So that's really important from a patient experience perspective. There's more to do. It's not perfect, and we need to continue to strive to do better. Our patient safety indicators are broadly stable. We have good reporting with low levels of harm, and our falls performance continues to be positive in terms of maintaining our positive performance in being below the national average. Our award accreditation, as you know, continues to expand. We'll have further silver and gold accreditations this month, with at least, I think, 3 more golds coming through, which is positive. And we've seen a positive improvement in terms of our safeguarding training performance. So despite the challenges with our safeguarding level 3, which is face-to-face, we are seeing improvements. And just a couple of challenges, really. We'll have talked about this in many forums, but violence and aggression towards our staff remains an area that we focus on, particularly sexual safety. And we continue to focus on our increase in our safeguarding referrals, although that is positive from a transparency perspective. And whilst we've seen a really pleasing improvement in our healthcare associated infections, particularly around E. coli and C. difficile, we are expecting an impact of the hot weather, because obviously hot weather means that that germs breed, people are more vulnerable. So we are expecting to see perhaps a downtick in July, but nonetheless, our improvement programmes have taken us to a position where in all but 2 infections, we are below the Orwell's benchmark.
Okay, thank you, Jen. Again, any comments or questions on the quality report? So in that case, the board is asked to note the progress against the key performance metrics of the latest available validated information, note the insight and actions identified in context performance achievement and look at progress against the enabling actions as of Q1. So happy to note and agree those. Okay, next item then is the update with the Regional Joint Committee. That's with myself. The report has been circulated, so I'm not going to go through the report. And as already been noted earlier, we covered this in the closed session this morning. And it also went to the Regional Joint Committee last week. So subject to any comments or questions from any members, I'll ask that we note the highlights set out in section 3 of the report, and also note the regional orthopaedic plan and Clantrison Health Park outline business case and full business case was approved by the board this morning in committee. Are there any comments or questions at this point? Are we just happy just to note? Okay, thank you. Move on then to item next item 5.5 on my agenda, which is nursing and midwifery strategy update and refresh. Mrs. Jen, please present.
Thank you. So you have 2 papers within the pack. The first is an evaluation of the 2023 to 2026 strategy, and you also have the plan which is looking ahead to 2030. I won't go through the strategy and the evaluation in detail, but just a couple of areas to highlight. So as I look back at 2023 to 26, we did set out quite a challenging plan in terms of our ambitions, particularly around making sure that we built that skilled, compassionate leadership workforce where we promoted leadership and inclusivity. And we did make a number of achievements. So I must say a huge thank you to Sarah's team, because really in the delivery of the plan, we couldn't achieve it without the work and support of Sarah's team. But we have achieved a number of areas, particularly around workforce development. We've standardised induction and preceptorship. We've improved the quality of appraisals. We've expanded our offer around reflective clinical supervision, and that's really about enhancing wellbeing and retention. We really focused on leadership development. We've developed our future nursing leaders, and we've tried to make sure that we promote those inclusive leadership behaviours. We also grew our quality improvement capabilities within nursing and midwifery to make sure QI is just something that we do. And you'll know from the story at the last board that that's embedded in our ward and team accreditation process. We've also expanded our advanced practice roles, particularly within research, digital maturity, and trying to make sure that we embed that professional voice. There have been challenges, particularly around the busyness of the system, but also workforce pressures. But we have significantly improved our RN recruitment position and our retention of our RNs, which is really positive. So, I would commend the evaluation to you and just some of the achievements we have made. And for anybody who came to the conference, I can't not mention the conference, but it was extremely positive. We reflect in the conference a lot on what we've achieved, and it was really lovely to hear the stories from staff around what they've achieved and how proud they are of nursing midwifery in an RN Bevan. We also had on the Monday our Internationally Educated Nurses annual event, and again celebrated the diversity of our nursing workforce. And we have nurses that have been with us 25 plus years, so it was lovely to hear those stories. Just in terms of the look ahead, again, I'll be brief, but we've built really on the foundations of the 23 to 26 strategy, so we're not starting anew. The Chief Nursing Officer for Wales has set out priorities for the next 3 to 5 years, so we've also built the plan on those. And what we've done is to make sure that we are we've focused on 8 interconnected priorities. But what we've tried to do this time is be really clearer around our actions, our measures and our timelines. So how do we make sure that we're able to demonstrate the value of the plan and what that means in practice? We've also, as part of this, strengthened our professional assurance framework. So each division, each team now has a professional standards action plan. They report that back to me on a bi-monthly basis. So we go through that to make sure that, I'm assured and they are assured on their progress. But that really focuses on their statutory and professional obligations, particularly the NMC requirements in terms of our code, but also make sure that we build on our safeguarding and equality duties and look to how we strengthen as a foundational nursing and midwifery workforce plan for the next 3 years. So I won't go through the priorities, they're there for you to see. But just to say, this plan has not been written by me or my team. It's been through significant engagement with our nursing staff. We did surveys, we did events with our teams, we engaged with Sarah's team. So this has been built from what our nursing and midwifery staff have told us they feel they need. We've significantly engaged with our trade union partners as well. So what we've tried to build is something that's sustainable for the future, that builds on what we've done and really looks to make sure that we are the best in Wales in terms of our nursing midwifery workforce. All's there.
Thank you, Jen. Put a pen in first, please.
It's great. Thank you, Jen. There's evidence of successful delivery against all 5 ambitions, which is great, and consistent progress, especially in the light of bad press, not bad press locally, but nationally. It's time it was overcome, and you know, you must highlight this. But however, one of the challenges is workforce challenges. I just wondered how you are dealing with this, and is it having a really negative effect?
Okay, Helen, thank you. Neil, I think.
Yeah, excellent report, thank you. And similarly, it's on the workforce point really, because it's excellent to see that there's expanded supervisory capacity within the team, but I also note that there's some more limited senior leadership capacity. So wanted to understand about the pipeline of bringing that forward, and just to say, you know, I think by definition this is a women-centered discipline, so it's really good to see, you know, aligning there, talking about better experience for women and families. Really welcome that language.
Thanks. Neil, please.
Yes, I'd like to commend actually the ambition and direction of travel. I'd just like to ask for some direction really as to what you would anticipate, Jenny, will be the performance, you know, the performance metrics that will be most positively impacted by this. So what we can expect in terms of performance.
If we take those 3 and we'll come back around then.
Right, so just in terms of the workforce challenges, I mean, they will, Penny, be interrelated to how busy our systems are, you know, how we can access and support staff in delivery of improved quality and outcomes. But I have to say, I think I said it at conference in my speech, whenever I go anywhere in this health board, and it is fairly unique from that perspective, the staff are positive. They get why we are making changes. They understand why the systems are busy and they work with it. We have great nursing staff out there, and what we've really tried to do is to build on that, to make sure where there are challenges, we wrap around them and support. And, you know, things like the restorative clinical supervision really help with that. With RCS, it is designed to give you time to think and reflect and, you know, have a moment to pause. We need to do more on the uptake of that. Staff aren't overly willing, but nonetheless, we've done really well if we compare ourselves to the rest of Wales. In terms of our pipeline for leaders, we've been working really hard with Sarah's team. So we have a number of programmes in place. It is always challenging, but people do tend to access those programmes. We need to make sure they still can access them. So we have a Band 6 development programme called Lead 6. We have the Nursing and Midwifery Academy, which builds our more senior leaders. And we've really tried to support our divisional nurses in terms of how we think about their future, whether they want to go on to a role like mine or whether they want to stay. So, you know, what are the opportunities to network nationally? What are the opportunities to support them and get them that downtime to do that thinking? But we've built that in as part of our plan and our work that we do with them. So I meet with them every month. I meet them with them group and individually every month, and we spend a lot of time thinking about what they need rather than, you know, me talking at them about what the organisation needs. It's an element of that, but it's really important they have that thinking time. And thank you for recognising our focus on women and families. There are male nurses, there are lots of them, and they are real advocates for our women who are nurses and their career pathways. And I should say that our internationally educated nurses have been fantastic in terms of reflecting back in that, you know, that equity approach across the health board.
And yes, it is very ambitious. We have tried to build some outcomes into the priorities, Neil. I hope you'll see that. But if we do this, we will expect to see, you'll have seen it in the ward accreditation presentation last time. We would expect to see improvements in quality and reductions in sickness, and in particular the financial impact of what those mean. We need to do more work, and Sarah and I have spoken about this, about how we evidence some of that. But I think it was quite stark to see when you start to play through what people have achieved with their ward and team accreditations and the impact it has both on patient and staff. I think that's where we need to focus, because ultimately finance, performance, quality and workforce go together.
Thank you, Chair. Just obviously to commend you for the strategy, but as the board's research champion, particularly to commend you, you've got research and quality improvement as a key theme through that, not only to improve patient care, but also to increase the professional ambition of the nurses and those who are involved with it. And just a quick question, which really follows on a bit from what Neil's already said. So you put us the action and how you're going to follow it up. Do we actually have, or are we collating now the baseline data so that we can see how many people move into new areas or take and accept the offers of courses and things like that?
Yeah, and thank you for recognising the research component, because it is, sorry, Andrew, I didn't know if there was another one. Sorry.
Yeah, big one in print for it.
I was enjoying that. Just not a statement and a question. The statement is just to thank all the staff and volunteers for the excellent work. We've been look at the challenging times recently. We know we have the Monmouth flood having to be supported, and then suddenly we get temperatures in the mid-30s, and that's another challenge in itself. But there's something that's been in the press recently has been about people who've been trained and haven't got any jobs. I think it's fair to say that we've had a look at this in a very creative way, and it may be worthwhile just expanding on that in terms of sort of what we're doing to support those who have been trained, got the qualifications, and we're, I'm saying looking after them, but looking at it in a very positive light.
Thank you. So it was sorry, I've got to stop doing that, haven't I? I'm going to make myself even redder. Okay, so yes, I recognise we really wanted to make sure that research was embedded, because nursing research is not where it needs to be in Wales generally, and we're ambitious as a group of EDONs about that, so we wanted to build it in. And yes, we will be working with Sarah and others around the baseline data. As you know, our quality data, we've now got a really good baseline. We now need to work through how we connect that with some of our other data to make sure we're able to demonstrate the value of nursing. And one of the pieces of work that will be done nationally will look at the value of nursing, because I think if you look at the research, actually nursing does very little in terms of demonstrating its value. So really important that we talk about the value of nursing. Yes, Paul, we've done a huge amount of work in our Bevan around streamlining and trying to make sure that we're able to secure as many jobs as possible, and, happy to take you through that at some point. But, the commitment Sarah and I have had is to try and ensure that we do, wherever possible, secure vacancies for those streamliners. Okay. We have done very well on other metrics like retention, which does make it more challenging. But Sarah and I have worked to look at our agency rates, to look at our fill rates and rostering. We've looked at creating site pools. So there are opportunities to bring in those streamliners as soon as we can. But it is a national challenge, as you know. You'll have seen the press, and there is a national programme of work looking at how we address some of that.
Just say thank you for that, because I think it has been a bit of a worry, and I think it's been looked at very creatively and innovatively. Appreciate it.
Thank you. Thanks, Chair. David, there's no more questions or comments on this report. To say thank you, Jen. And the board here is asked to note the successful delivery of the 2023-2026 nursing, midwifery and SCHPN strategy, and support the development of the refreshed nursing and midwifery professional plan, which is the 2026 through to 2030, aligned to the national priorities, workforce and clinical service, and ensure transformation. Again, so we're on board content to make the report. Yes, okay. We'll go on to the next item, which is team out the strong committees of the board. So by exception, I'm just going to ask the chairs if there is anything from the reports and the updates from committees that we wish to raise. Please.
Yes, it's nothing directly involved with our committee, but it's to do with a patient safety visit and mental health. It's to do with the estates. Tracy and I went on a patient safety visit, and some very concerning issues came up. And I know that you're going to deal with it, aren't you? But I just thought at this stage I should flag up that we really are concerned about some issues. So hopefully it will come back to the committee.
Okay, I think it's worth flagging, and certainly I know we've had discussions about the wider mental health estates across the health board. And I know there's work ongoing with that, and at some point that's going to come back to board in terms of options going forward. So I think it's worth to keep a close eye on in terms of the safety and what we think is appropriate.
Thank you. If I could come back on that. So yeah, thanks, Kenny. I'll follow up with Tracy as well. So obviously the mental health services was a priority for us locally and nationally. There's quite a big focus on the national plan for mental health as well, and we obviously working proactively around that anyway. The estate issues is one of our key concerns as well, but important if there's interim work we should be doing there, we need to make sure there's appropriate escalation and follow-up. So we pick for safety reasons for staff, because we need to make sure that in the interim, because these are not always quick fixes, that our accommodation is as fit for purposes it can be. So thank you for this.
Thank you, Penny. If there's no other chairs wish to raise any by exception, I move on to the next item then, which is the digital data and technology transformation strategy, putting digital and data to better work, health, better care and better lives. And all these
Yes, Chair. So our strategic digital transformation plan brought today is the digital response to Gwent 35, our 10-year health board strategy, which sets up digital as one of the key enablers. This clear technology can help support integrated services, better access to care, stronger community services and improved coordination across organisational boundaries, and ultimately improving the health of our local communities. The plan sets out the alignment with the three aims of Gwent 35, supporting better health, better care, better lives, but also alignment to the Welsh Government digital strategy and contributing to improvements in quality of care, experience of the workforce and financial sustainability. The vision laid out in the plan aims to create a digitally enabled health and care system that empowers and connects our communities, supports our workforce and improves outcomes. And the objectives of this plan will be to enrich workforce experience, engage with our communities, improve clinical and operational workflows through digitisation, and maximise opportunities for innovation with industry and academic partners. This vision and objectives will be supported by a set of core principles, ensuring we always put people at the centre, that we build safety in from the start, reduce the burden of some of the existing digital services we have, and ensuring we are always service-led. There are strategic risks which will need to be managed, including our legacy technology, the pace of change associated with new technologies such as AI, some of the funding challenges we will have, and addressing digital exclusion within our communities. So the vision and objectives will be realised through 4 strategic missions. So mission 1 is digital health and care, connecting people with services. So core to this mission is providing patients access to digital services, supporting self-management and access to trusted information. We will also improve our digital health and care record capabilities, ensuring all healthcare professionals have access to the information they need at the point of care. The adoption of AI and automation technologies to improve productivity and efficiency and also help solve some of the healthcare challenges that we have. And also how we can use technologies such as Microsoft 365 to adopt a digital first approach across the organisation. So mission 2 then is around designing with data to drive improvement. So this mission is about how we use our data to improve organisational decision making, planning of services, service improvement and supporting population health management. Key to this mission is the development of a data and analytics academy to drive data maturity across the organisation through a skills and development programme. And the National Data Resource is a critical enabler of this mission, using modern cloud technologies to deliver a single version of the truth and support data sharing across the organisation and our wider healthcare partners. So on to mission 3, which is around digital foundations, fit for today, ready for tomorrow. This mission acknowledges to deliver digital transformation, we need strong, secure and resilient digital foundations. This includes an open standards-based digital platform, aligning with the work underway around the national target architecture. Integration services to ensure that we share our information to support patient care wherever it is delivered across the system. Delivery of our digital support services in line with best practice frameworks and fast and reliable wired and wireless networks. We'll also continue the removal of paper through the continuation of our scanning programme, ensuring all of this is underpinned by strong cybersecurity resilience and information governance arrangements compliant with relevant legislation. And on to mission 4, building organisational capability for digital transformation. This mission ensures we develop our people to sustain digital transformation, both within digital teams, but also wider across the organisation. And again, we will work in line with the digital blueprint that's currently being developed nationally. This will be achieved through assessing the digital capability of the workforce and delivering structured skills development, improving digital confidence. We'll also strengthen our governance arrangements, ensuring benefits are realised by improving the patient safety, delivering efficiency and productivity savings, and ultimately releasing cash saving benefits, and then providing assurance to the board through those governance arrangements. And finally, we'll also look at innovation opportunities through partnership working. So the final section of the plan then talks about the implementation approach. So it will be delivered in a phased approach aligned with any national policy position, clear standards, good governance, and adopting regional working where there are synergies. This phased approach will get the foundations right, deliver immediate priorities while moving towards extending digital services, joining up care and improving our digital maturity over the longer term. A strategic partner will be employed to bring expertise, global best practice, and plug gaps in skills and knowledge, whilst our own local teams are skilled up. This strategic partner will support the Health Board as an anchor institution with strong corporate social responsibility. So this delivery will be supported by a benefits management framework, ensuring digital investment delivers measurable value and benefits that are captured across the organisation. These measures will ensure we can provide assurance that digital transformation is delivering that better health, better care, better lives for our communities across Gwent. A strong engagement with our divisions and clear visible processes for service requesting will ensure digital transformation is service-led at all times, with transparent prioritisation and a jointly owned plan. And our programme structure will align with the Gwent 35 programme to further ensure that strong strategic alignment. Finally, the paper outlines the approach to risk management and delivery in the context of a challenging financial landscape. As the board's asked to approve the plan for publication and endorse the mission-based framework and also the implementation approach that we've set out. So that's what I'm saying. Thank you, Chair.
Thank you, Paul. Go round, members. David first, please, and I'll come to Akron.
I don't have any questions. Paul and I have talked quite a bit about this particular strategy, but I'm really pleased to see us come to the board. Obviously, digital tech is going to be a huge enabler for us to be able to deal with the many challenges I think we've got as an organisation. And as we've heard in various plans today, in both parts of this board, it's digital is an enabler to help us change a lot of how we work. It's not going to be an easy journey. We've got lots of constraints, not least the fact that Wales funds digital transformation at a substantially lower rate than pretty much anywhere else in the UK. Our baseline is much lower than everywhere than all the other countries combined, I think, and the whole system it makes things a bit difficult. But Paul and the team has work cut out for them. I'm really pleased that we've got this. We've got this here. Got a strategy that we can work to and some plans to take it forward. So hopefully we can embed that in the way we work and use that to change how we deliver everything inside AV.
Okay, there's a few hands. Can I just ask one question? You mentioned about the further expansion of digital technology. Are we trying to embed the principles of having a paperless health board So just to reassure people that there is always going to be a need for some paper in an organisation, but the general principle is that we are just not creating paper records that we end up having to back scan. We're not creating records that in some cases people have to, they're physically input into a different system because it doesn't read from the paper copy. And also the fact that we move away from the likes of colour photocopy and just general photocopy is an important principle. So I just wondering, is that something as a ethos in the organisation that we are moving to that position in principle of trying to become a paperless organisation wherever that is suitable?
Yeah, so within the mission framework, one of the goals is around how we stop creating paper within our scanning function. So that's the use of eForms technology, which was our key first developments that we want to take forward to stop creating paper in the first place. So that will cover the clinical elements and also that integration approach I said, which will share information across systems. And then finally, then how we can, from the non-clinical perspective, how can we use Microsoft 365 and some of the tools in that platform to modernise how services are working from a digital first perspective to remove that paper from the system.
There's a few, so Akmal, then I think it was Neil and then Paul.
Yeah, well, thank you, sir. It's quite a lot of work, Paul. Thank you so much for sharing this digital data strategy. My question really is about understanding, that we as a health board, we are sitting on a data goldmine. And the data collection points are, I think, very important in terms of getting that strategy forward. So what I would like to see or get some more assurance is that what are the live data points or projects that you think that are going to be very important to be able to get the data is being fed in to be analyzed in a way to help the divisions and the decision makings that we do based on that evidence and that data. So how does that circle actually complete? Because I can see there's a lot of that strategy about the digitalization of the organization, but I think collecting data is a challenge, analyzing data is a challenge, and using that data for evidence-based decision making. I mean, how is that going to work through this strategy?
Yeah, so sorry.
Neil, next please.
Yeah, actually, my point is connected with Akmal's point, but I'm taking a slightly different slant on it, which is I think that the plan as you've presented it, it excites me in terms of the number of potential performance metrics that we could see going forward as a result of the successful implementation of this. And my comment was actually to say that I think we should try really hard not to appreciate the difficulty of the project, but actually we shouldn't overlook the opportunity within it to actually extract a huge amount of evidence of the value of that technology. So let's not miss that opportunity.
Okay, thanks. Paul, next please.
First of all, excellent paper, Paul. Thank you to you and your team on it. And I very much like the Gwen 35 linking in with health, public health and the prevention agenda, which I think is incredibly important, and the strapline of better health, better care, better lives. 3 areas really. I just wondered whether at some point, not necessarily now, we can look at the children and young people offer, because I think that's going to be crucial to the next phase or stage in terms of the development of the digital. Also to be reassured on cybersecurity and the risks with all this, because we are developing more into digital risks there. And thirdly, the opportunity of use of AI as well for staff and for patients and for board members, I suppose.
Okay, so just on Akmal's point, so yeah, completely agree. So alongside this, we have our data analytics strategy, which was already in place from last year. So we're now about to launch our data analytics academy that I mentioned earlier. And one of the key things there is a lot of the health board data is already now in the national data resource, and there's plans this year for social care data to go in there as well. So as we digitize our services, all of that data is going to be flowing in to the end, yeah, and there's an opportunity then we'll have that large cohort of data that we can then use for whether that's planning or service improvement using some of those modern data tools that we're going to have available. And through that academy, we've identified 3 levels of information users across the organisation. We've got a structured training program we're going to put in place for each of those 3 levels. We bring the data maturity of the organisation up at the same time, so they understand how to make the best use of the tools that are out there. Just on Neil's point, yeah, I completely agree. I think that's the importance of our benefits management framework, which will ensure that before we do any digital initiatives, we capture that baseline of where we are, and then we track then what the benefits that we're going to deliver over the life cycle of that project, and then report on in time as well. And then just on the children and young people, yeah, I completely agree, Paul. Fair enough. I think we Lisa spoke about this when I discussed the strategy with Clive about how we can use some of the patient participation panels they've got to understand what their digital needs are going forward. So that'll be an important element of that, you know, improving our digital offer to our communities. Yeah, cybersecurity is just absolutely key, as you can imagine, and that's one of our core missions, is to make sure that everything we do is safe. And I'll continue to provide assurance on where we are with cybersecurity across the organisation. And then AI, yes, completely agree. As you know from a recent board in January, we've got our AI governance in place and the relevant AI subgroup. I guess the next step for me is, what do we want to use AI for? What problems we trying to resolve? And that's something that we'll be working with our divisional colleagues through our engagement meetings as we move forward. And obviously we're working with Microsoft on kind of pushing out Copilot now, because now we've got additional licenses. We'll obviously be looking to push that out wider across the organisation as well.
Great, thank you.
Thank you. And Seema, please.
Yeah, thanks, Paul, and yeah, really supportive, and there's some really exciting we've discussed before, but I just wanted to highlight, and it relates to some of the performance and quality questions around digital, is that we've got real opportunity with those structured digital clinical forms to embed performance and quality within those forms, so you're not having to sort of reverse and look for the information. It will just be built in and we can extract it. So that's the opportunity that other organisations have captured. So we're really looking forward to being able to do that.
Thanks. Just one final point, just something that popped in my mind, just what David saying about the finance. You may be aware that Welsh Government have brought in Tara Donnelly from NHS England to look at a 10-year digital strategy for health and care in Wales. So it'll be really interesting to see what that's going to deliver. I think it's due to be completed by early next year. So it'll be interesting to see if that picks up some of the funding challenges that we've got in Wales.
It's interesting. One of the conversations I had yesterday with the chairs with Welsh Government, where they were asking about identifying some of the key priorities, what we really want to focus on. And it came up a number of times, just saying, actually having one digital system that between health boards, we could all speak to each other with information freely, because so many of our services are provided across different health boards. And it was mentioned about Building various other partners and health organisations. So I think it is now becoming more of a priority for Welsh Government. The fact that they were asking the chairs yesterday again around focusing on a small number of areas that we really focus on the next couple of years. Okay, if there isn't any further comments or questions on this, the board is asked to approve the plan for publication and endorse the strategic direction and the framework and implementation approach. So you're content and happy to agree this? Okay, we move to the consent agenda, which is item 6, which is quite a long list of areas. Just want to pick on a couple of areas if we could. Nicola, as Chief Executive, would like to come in on just 1 or 2 first. I was going to ask then if Lisa from Place would like to comment on Michael. Lisa, you've been with us all day, so if I come to Nicola first.
Yeah, I don't want to go into the report in detail, but I just want to kind of draw out the communication engagement annual report, and I've got a very busy end of the day, so we're not going to do it, but just kind of it's a very thorough report. I think it captures the breadth of the work that the communication engagement teams do across both the public and staff, and just want to kind of record my thanks to the team for what's been navigating a fairly challenging 12 months really, in terms of the attention on health services in particular and the health board. So just wanted to draw that. Thank you, Chair.
Okay, thank you. I got Lisa. you like to comment or add anything to your report, please?
I take the report as read, Chair, but happy to take any questions. I wanted to alert the board to some of the key position statements that LICE has released recently across Wales, in particular with regards to corridor care and same-day urgent care, and understandably both of those subjects was on the agenda, and I know various priority programme boards have been set up, so many thanks for that. But just wanted to alert that, and also I guess around mental health continues to be an area that causes concern through our complaints advocacy service in particular, and that's locally as well as across a Welsh footprint. So I'm happy to take any questions here and now or after the board if you'd like to reach out, and we can have a separate conversation.
Okay, thank you, Lisa. I can't see anybody indicating you're content with the areas listed in 6.2. We just accept and note them. In that case, I'll move on to item 7, which is any other business. Are we have any other urgent business for today? And just to note, the next board meeting is the 16th September 2026. It was today's meeting, so thank you, everybody. Thank you.
Thanks, Naomi.